A 67-year-old woman sits on the hospital bed. She lifts her trouser leg. Her ankle is the size of a grapefruit. She looks at you and says, "Doctor, my legs have been like this for 3 weeks. Nobody tells me anything." Is it her heart? Is it a clot? Is it her kidneys slowly shutting down? You need to find out right now, in English. And every word you choose matters. Welcome to Medical English Pro, the channel for healthcare professionals who want to communicate with complete confidence in English clinical settings. Today, we're starting a 2-part deep dive on lower limb swelling, one of the richest, most clinically demanding topics in medical English. This is part 1. In this video, you will get 3 core blocks of clinical English. First, why this symptom matters and what you need to be able to do in English. Second, a complete vocabulary masterclass with pronunciation, definitions, and real clinical sentences. Third, a full history-taking consultation, phrase by phrase, from the opening to the medication review. In part 2, we'll move into physical examination language, differential diagnosis, patient communication, and a complete OET role play. Let's go. Section 1. Why this symptom demands your best English. Let me start with a number that might surprise you. Lower limb edema, that's the medical term for leg swelling, is one of the top 5 presenting complaints in primary care and emergency departments across the United Kingdom, Australia, and the United States. 1 in 5 patients admitted to internal medicine wards will have some form of peripheral edema. This is not a rare condition. This is bread and butter medicine. And yet, for many international healthcare professionals, the language around this topic is a serious gap. Why? Because the vocabulary is deceptively complex. The causes span every organ system in the body, and the patient, the real human being sitting in front of you, needs you to explain what is happening to them in plain, reassuring English. Let's build your language toolkit, layer by layer. Section 2. Core Vocabulary Masterclass. 2A. The condition itself. Our first word is edema, spelled O-E-D-E-M-A in British English, E-D-M-A in American English. Both are correct. Know both. Edema means an abnormal accumulation of fluid in the interstitial space, that is, the space between the cells in your body's tissues. In a sentence, the patient presented with bilateral pitting edema of the lower limbs. Next, peripheral edema. Peripheral means far from the center of the body. Peripheral edema is swelling that occurs in the extremities, the legs, ankles, and feet. In a sentence, peripheral edema is a common sign of right heart failure. Third, lymphoedema. This is edema caused specifically by impaired drainage of the lymphatic system. It's often chronic, long-lasting, and in advanced stages it becomes non-pitting. In a sentence, she developed lymphoedema following her axillary lymph node dissection. Fourth, dependent edema. Dependent means that the fluid collects in whichever part of the body is lowest due to gravity. In patients who walk around, that means the ankles and feet. In patients who are bedbound, it collects at the base of the spine, the sacrum. Remember that word, the sacrum. We'll come back to it. In a sentence, check the sacrum for dependent edema in patients who are bedbound. 2B. The critical adjectives. These adjectives are the difference between a vague description and a precise clinical one. Let's go through them carefully. Number 1. Pitting. When you press firmly on the swollen area, a dimple, a pit, remains in the skin for several seconds after you release. That's pitting edema. It tells you that the fluid in the tissues is free and mobile. In a sentence, on examination, there was marked pitting edema extending to the mid-calf. Number 2. Non-pitting. When you press, the skin springs back immediately, no dimple. This suggests the fluid is protein-rich or that fibrous tissue has formed. You see this in lymphedema and in a condition called myxedema. In a sentence, the edema was non-pitting, raising suspicion of underlying lymphatic obstruction. Number 3. Bilateral. Bilateral means affecting both sides, both legs. When edema is bilateral, think systemic, something going wrong throughout the whole body, such as heart failure, kidney disease, or liver disease. In a sentence, bilateral edema with a raised jugular venous pressure pointed towards right heart failure. Number 4. Unilateral. Unilateral means only one side, one leg. When edema is unilateral, think local, something happening specifically in that limb, such as a blood clot, an infection, or a blocked lymph node. This is critical. Unilateral acute swelling means you must rule out DVT, deep vein thrombosis, immediately. In a sentence, unilateral calf swelling with redness, DVT until proven otherwise. Number 5. Gravitational. Gravitational edema is caused by prolonged standing or sitting. Gravity pulls fluid downward into the ankles. It's typically worse in the evenings and better in the mornings after lying down overnight. In a sentence, the gravitational nature of her edema, worse in the evenings, resolved by morning, suggested venous insufficiency. Number 6. Erythematous. This adjective means reddened, describing skin that is red and inflamed. It's important when edema is accompanied by infection or clot. In a sentence, the edematous limb was warm and erythematous, consistent with acute cellulitis. 2C. Anatomical landmarks. You need to be able to point to and name the exact location of the swelling. Here are the key anatomical terms. The malleolus, plural, malleoli, the bony bump on each side of your ankle. The medial malleolus is on the inner side. The lateral malleolus is on the outer side. This is the classic spot where you press to test for pitting edema. The dorsum of the foot, the top surface of the foot, often the first place where visible swelling appears. Edema extending from the dorsum of the foot to the mid-calf. You need that phrase. Pretibial, in front of the tibia, the shin bone. Pretibial edema is pressed against the flat surface of the shin. Pretibial pitting edema, grade 2+, bilaterally. The popliteal fossa, the hollow behind the knee, important for examining swellings behind the knee. The sacrum, the triangular bone at the base of the spine. Remember, in bedbound patients, dependent edema collects here, not at the ankles. Always examine the sacrum. 2D. Key causes, vocabulary for differential diagnosis. Now, the causes. You need to be able to name these fluently because in a clinical exam, you'll be expected to articulate your differential diagnosis out loud. Deep vein thrombosis, DVT. A blood clot forming in a deep vein, usually in the calf or thigh. The most urgent diagnosis to exclude when a patient has acute unilateral leg swelling. Time-sensitive, must not be missed. Chronic venous insufficiency. The valves in the leg veins fail to prevent blood from flowing backwards, leads to chronic bilateral gravitational edema, very common in older patients. Hypoalbuminaemia. This is a mouthful, but you need it. Hypo means low. Albumin is a protein in the blood that maintains fluid inside the blood vessels. When albumin is low, fluid leaks out into the tissues and causes edema. Causes include liver cirrhosis, nephrotic syndrome, and malnutrition. In a sentence, her edema was secondary to hypoalbuminemia from end-stage liver disease. Cellulitis, bacterial infection of the skin and the tissue beneath the skin. It presents as unilateral, warm, red, tender swelling. Requires antibiotics. Lipodermatosclerosis, a long word for a very recognizable sign. Chronic venous disease causes the skin of the lower leg to become hardened, brown, and narrowed. The leg looks like an upside-down champagne bottle. It's a sign of long-standing venous insufficiency.
A quick quiz is appearing on screen right now. Pause the video, think about your answers, and write your answers in the comments we'll discuss. Section 3. History taking, the clinical consultation. Now we move from vocabulary into real language in action. We are going to walk through a complete history-taking consultation for a patient presenting with leg swelling. I will show you the clinical question, the purpose behind it, and the precise English phrasing at B2 to C1 level that you should be using. Our scenario, a general practice surgery. Dr. Patel calls in Mrs. Nowak, 64 years old, who has noticed both ankles swelling over the past 6 weeks. 3A. Opening. Establishing the presenting complaint. Always open with an open question. Do not ask yes or no. Let the patient tell their story first.
Mrs. Nowak, what's been bringing you in today?
It's my ankles, doctor. They've been swelling up. Both of them.
Thank you for coming in. Can you tell me a bit more about when you first noticed this?
It started maybe 6 weeks ago, I think. At first, I thought it was the heat.
That's a really useful detail. And has it been getting better, worse, or staying about the same since then?
Notice what the doctor does there. Acknowledges the patient's contribution. That is a really useful detail. 3B. Character of the swelling. Now we go deeper, exploring exactly what the swelling is like, using a systematic framework. Here are the key areas to cover. First, the site. Where exactly is the swelling? Say, is the swelling in both legs or just the one? Or, can you show me exactly where it starts? Or, does it go above the knee at all, or is it just from the knee down? Why this matters? Bilateral edema points to a systemic cause, heart, kidneys, or liver. Unilateral points to a local cause, clot, infection, or venous disease in one limb. Second, the onset. When and how did it start? Say, when did you first notice the swelling? Or, did it come on very suddenly, over hours, or more gradually, over days or weeks? Or, was there anything happening around that time? A long journey, an injury, an illness, starting a new medication? Clinical note, acute onset, under 72 hours of unilateral swelling means DVT, cellulitis, or trauma until proven otherwise. Gradual bilateral onset over weeks means heart failure, venous insufficiency, or hypoalbuminaemia. Third, the character. What does the swelling look and feel like? Say, if you press on the swollen area, does it leave a dent, like pressing into a memory foam pillow? Or, is the skin over the swelling shiny or taut, stretched tight? Or, is it painful when you press on it, or is it painless? Or, does the skin look red or feel warm in that area? The memory foam pillow metaphor is powerful. Use it. Patients immediately understand pitting edema when described that way. Fourth, the timing. Is there a pattern through the day? Say, is the swelling worse at any particular time of day? Or, is it better in the morning after you have been lying down overnight? Or, does it get worse as the day goes on, particularly in the evenings? The classic gravitational pattern is minimal in the morning and maximal in the evening. This points to venous insufficiency or cardiac edema. Swelling that is constant and does not improve with elevation is more concerning. Fifth, aggravating and relieving factors. Say, does keeping your legs raised help, for example, resting them on a footstool? Or, have you noticed it's worse after long periods of sitting or standing? Or, do you wear compression stockings? If so, do they help? 3C. Associated symptoms, the systemic screen. This is where you show your clinical intelligence. The associated symptoms reveal the underlying diagnosis. These questions help identify which organ system is involved. For the cardiovascular and respiratory screen, ask, have you noticed any shortness of breath? Do you find you get more breathless lying flat? Do you need extra pillows at night? That last symptom has a name, orthopnea, spelled O-R-T-H-O-P-N-O-E-A, pronounced orthopnea. It's a classic sign of heart failure. For the renal, that is, kidney screen, ask, have you noticed any changes in how often you pass urine or in the color? Is your urine foamy or frothy? Foamy urine suggests protein is leaking into the urine, a sign of nephrotic syndrome. The medical term is proteinuria. Proteinuria. Have you had any swelling around your eyes, particularly in the morning? That's called periorbital edema, periorbital, and it's a classic early sign of nephrotic syndrome. For the hepatic, liver screen, ask, have you noticed any yellowing of your skin or the whites of your eyes? That's jaundice, a sign of liver disease. Has your abdomen been swelling as well? Fluid in the abdomen is called ascites, common in liver cirrhosis. For the DVT, always with any unilateral swelling, ask, is the swelling only in one leg? Is that leg more painful than the other, particularly in the calf? Is the leg red, warm, or a different color compared to the other? Have you recently been on a long journey, a flight, or a long car trip? Have you had any recent surgery, or have you been less mobile than usual? Have you ever had a DVT or a pulmonary embolism, a clot on the lung, before? 3D, medications, the hidden cause. This is one of the most commonly overlooked causes of leg edema, and it's essential in your history. Many common medications cause or worsen peripheral edema. Ask every patient, are you currently taking any medications, including anything bought over the counter or herbal? Has anything changed in your medication recently? Anything added or stopped? The key culprits are calcium channel blockers, especially amlodipine. This is a very common cause of ankle swelling. Also, non-steroidal anti-inflammatory drugs known as NSAIDs, ibuprofen and naproxen, corticosteroids, hormonal treatments such as estrogen, and gabapentin and pregabalin, which are frequently overlooked. When you identify a medication cause, here's how to explain it to the patient. One of the medications you've been taking, amlodipine, can sometimes cause fluid to build up in the ankles. This is a recognized side effect. It doesn't mean the tablet has harmed you, but it is worth reviewing together.
And that is where we are going to pause, right here at the end of Part 1. Look at everything you have just built. You now have the full vocabulary of lower limb edema, 20 terms with pronunciation, definitions, and real clinical sentences. You understand why this symptom demands your very best English. And you have a complete history-taking framework. Every question, every screen, every phrase, from the opening to the medication review. That is already more than most candidates walk into an OET exam with. But we're not done. In Part 2, we'll go further. Physical examination language, differential diagnosis, patient communication, and complete OET role-play. Subscribe and hit the bell not to miss it. Follow Medical English Pro.